Hello, I'm Mary Beth Marsden, and welcome to GBMC's Ask the Oncology Expert. Joining us today is Dr. David Gottlieb, who is a medical oncologist and hematologist with the GBMC Sandra and Malcolm Berman Cancer Center. Dr. Gottlieb, thank you so much for being with us.
Hi, thank you so much for having me.
Okay, so we have to come right out of the gate and welcome you to GBMC. You're a relatively new doctor here, so just tell us about why here, what's your first impressions, how long you've been here, et cetera, et cetera.
So I've been in Baltimore for a little over 6 years now, and at GBMC for only about 3 months so far. Um, I really liked GBMC for a number of reasons. I think number one is the reputation that it has in the community, both of providing excellent care, but also very kind of warm, compassionate care, and having a real culture of being really exceptional. Those are kind of the main.
So medical oncology is your field, specifically hematology, I guess, as well. What is medical oncology if you were to define it?
So I typically think of the ways that we can treat cancer as, there are three main different ways. There's surgery, surgical oncology, where you can cut out a cancer or tumor and remove it from the body. There's radiation oncology, which uses high dose radiation energy to damage cancer cells' DNA. And there's medical oncology, which uses medications, medicines to treat cancer. So that includes traditional cytotoxic chemotherapy, but also any targeted therapies, immunotherapy, pretty much any medicine to treat cancer is part of medical oncology.
And I know, of course, part of the beauty of the Cancer Center is that there's a whole team of people working together with their various specialties.
Yeah, it's very, very collaborative here at GBMC. We have multidisciplinary tumor boards. We're in constant communication with various different providers from other fields, radiation oncology, surgical oncology, urology, other subspecialties, and also the entire kind of cancer care team, the nurses, the medical assistants, all the support staff. It really is a good culture here.
And do you mostly focus on blood disorders?
Um, I right now, as one of the newer providers, I'm seeing a lot of hematology, a lot of benign hematology, but I see a little bit of everything. So blood disorders, um, including blood cancers, and then also solid tumors.
And you know that we've collected a number of questions from people who are tuned in right now and they wanted to hear your perspective and they had very specific questions depending on what their needs were. But this one is pretty broad, and you talked about various blood disorders and possibly cancers as well. But when do you know that a blood disorder would require a medical oncologist or hematologist?
Yeah, so I guess broadly speaking, the bone marrow makes three different types of blood cells: the white blood cells that fight infection, the red blood cells that carry oxygen to the tissues, and the cells that make platelets, which help form blood clots. So there are a lot of both benign and malignant processes that can go on or that can go wrong. Um, so some of the things that I see are some of the benign hematologic things that I see include abnormal bleeding disorders, abnormal blood clots, DVTs, PEs, hypercoagulable states, anemia, iron deficiency, other nutritional deficiencies, thalassemia, sickle cell. Um, those I kind of encompass some of the um, benign hematologic disorders, any platelet disorders, etc. Um, the malignant heme disorders include the lymphomas, um, and acute and chronic leukemias, as well as some of the bone marrow failure syndromes and things. Yeah,
The blood, it's so fascinating. I mean, the blood can tell us so much about what's going on with us. It also can be kind of a puzzle, right?
absolutely. It's one of the things that absolutely, amongst a number of things, kind of draws me to the field. Is really, kind of doing some detective work and critically analyzing the tests and the results and figuring out kind of precisely what test may need to be run to give the answer that you need. Yeah, it can be a fun field to work in.
So in the time that we have, I want to make sure I get to all these questions. The next one is there targeted treatments for the various blood disorders and cancers that you specifically treat?
Yeah, absolutely. So targeted therapy, as opposed to kind of traditional cytotoxic chemotherapy, which broadly kills rapidly dividing cells, which include cancer cells, but also other types of cells, whether it's hair follicle cells or other cells. Targeted therapy is kind of a relatively new and exciting kind of frontier in medical oncology, where we know that certain cancers either express specific genes that are driving the cancer, driving the cells to continue to replicate in an unrestricted way and thus kind of turn into cancer. And for a number of those types of cancers, there are genes that we have specific targeted therapies that really attack and turn off those genes precisely. And it can be really cool. It's a more focused kind of targeted attack that can be very, very effective against the cancer, while also having in general a better side effect profile, less kind of off target side effects or damage.
You get the sense now with oncology that every patient's treatment is so specific to them that there's no such thing anymore as sort of this broad overriding treatment that everybody gets.
Yeah, absolutely. I think that's another thing that really actually drew me to the field is how rapidly all of this is evolving and expanding. It's a very exciting time both to practice medicine, to practice oncology, and if it can ever be exciting to be a patient or a cancer patient, there's sort of no better time, with so many emerging things coming out. I mean, all of the treatments are really individualized, both an individualized care plan that I'm making, individually with the patients, but really also collaboratively too with my colleagues to come up with, an individualized, comprehensive treatment plan for each individual person's cancer, and taking into account each individual person as an individual as well.
Yeah, it certainly is hopeful for the individual who's dealing with a cancer diagnosis, just to hear about the things that are happening now and possibly on the horizon soon. Is there a genetic predisposition for leukemia or any other blood disorders or cancer?
Yeah, so in general, the majority, I would say, of cancers occur due to acquired or somatic mutations that are not passed down, genetically within families. Most of the leukemias are that way, and lymphomas, and certainly a lot of solid tumors as well. That being said, there are certainly some genetic syndromes that are associated with an increased risk of cancer. Kind of most famously are the BRCA mutations, BRCA1 and BRCA2, which are associated with an increased risk of breast and ovarian, prostate, pancreatic cancer, and a number of other different kind of genetic or heritable cancer syndromes. I would say, the most important thing is probably if you have someone in your family who if you have a family history of cancer, if someone in your family gets diagnosed with cancer, particularly if they're diagnosed at a young age, or if you have multiple family members with a diagnosis of cancer, it's important to talk to your doctor about, is there a potential that there may be some inherited genetic risk factor that you may be tested for.
Yeah, possibly things to be on the lookout for. What is the difference between a blood disorder and a cancer of the blood?
Sure. So I guess, all blood cancers are blood disorders, but not all blood disorders are cancers. So, as I mentioned, a blood disorder can be an abnormal blood cell count. It can be too low of a hemoglobin, of a red blood cell count, which is anemia, for which there's a number of causes. It can be, increased numbers of platelets or white blood cells, or decreased numbers. Certainly, any of the clotting disorders or abnormal bleeding disorders, some of which also can have some genetic components to them, certainly. Those, I would consider those to be blood disorders, but many of those are not blood cancers. The blood cancers, as I mentioned, leukemias, lymphomas, some of the plasma cell disorders such as myeloma, some bone marrow failure syndromes and other. I guess the distinguishing factor is if there is a clonal population of blood cells that is growing or expanding unrestricted and therefore kind of causing problems. That's what defines this as cancer. If you have to have clonality. If it is just a high or a low number of blood cells, that's not necessarily cancer.
What's the difference in treatment of a blood disorder and or versus a blood cancer such as leukemia?
Yeah, I think it's very, very individualized based on the specific disease or disorder. For example, if someone has anemia from iron or B12 deficiency, the treatment may be to replace, iron or B12, for example, replace the underlying nutritional deficiency. Usually fairly straightforward with minimal side effects, etc. Certainly, there are many benign blood disorders that have much more complicated treatment kind of parameters and algorithms. And blood cancer also kind of, depends, for leukemia, many times that's chemotherapy or a combination of high intensity chemotherapy for acute leukemias. For chronic leukemias, sometimes often targeted therapy, sometimes in combination with immunotherapy. And for the lymphomas, depending on the type of lymphoma, some of which require fairly intensive chemotherapy and chemoimmunotherapy using a combination of chemotherapy and immunotherapy. And other lymphomas are more indolent and can just be monitored and don't cause problems sometimes for many years or decades even. So it's really, it's very, very individualized depending on the specific disorder.
Speaking of specific disorders, what is multiple myeloma?
Yeah, so multiple myeloma is a plasma cell disorder. Plasma cells are fully mature B cells, which are one of the immune cells, one of the white blood cells. Normal B cells are the cells that make antibodies. That's kind of their role in the immune system. We've heard a lot about antibodies and antibody testing recently since the COVID pandemic began. And B cells are the cells that make antibodies. Antibodies are proteins that recognize and bind to other proteins on the surface of other kind of foreign invaders, whether it's viruses, bacteria, or other things. So that's the normal function of a plasma cell, is to create antibodies. In multiple myeloma, you have an abnormal population of plasma cells that, again, are clonal, that instead of kind of all being a little bit different from one another, are all exactly the same. And they're not functioning, they don't function as well as a normal non-myeloma plasma cell would, and can expand it inside the bone marrow and cause problems. So typically, the bone marrow maybe has 2 to 3% plasma cells at any given time within it, but in multiple myeloma, you often have many more, sometimes as many as 60% or more, and this can cause problems including bone weakness and elevations in calcium. It can cause anemia. It can cause kidney dysfunction for people at risk of infection, etc.
It's interesting when I hear you talking about this, and we think of often other types of cancers as involving a tumor or a mass. And when you say clonal, this isn't necessarily a tumor, right? It feels like the blood is so constantly on the move. It's this whole different thing.
Right, exactly. There is an entity called plasmacytomas where you have a solid tumor essentially of these abnormal clonal plasma cells. But in general, for multiple myeloma, there's not a specific mass or a specific tumor because these are circulating blood cells. It's just that there's an abnormal population of them and too many of them, and they cause problems. So,
someone has just asked, how is multiple myeloma treated? You touched on it a little bit.
Yeah, so multiple myeloma is treated. There are a number of different really mostly kind of targeted therapies that use different mechanisms that we use kind of together in order to treat myeloma. There's been some recent advances, including some monoclonal antibodies that have really, I think, revolutionized the field. And there's a lot of exciting things kind of coming down the pipeline for treatment of myeloma. Multiple myeloma is in and of itself an incurable disease. It's not something where any treatment, whether that's targeted therapy, chemotherapy, surgery, radiation, nothing that we have, we don't know how to cure multiple myeloma. So the goals of treatment are to control the disease, to prevent it from progressing or getting worse, prevent it from causing, organ dysfunction, and ultimately the goal of controlling the disease is to allow people to live longer while maintaining the best quality of life. And fortunately, with many of the recent advantages in multiple myeloma, many people are living much longer with a very, very good quality of life than ever before. So.
What is smoldering multiple myeloma?
Yeah, so smoldering myeloma, the way that I think about the plasma cell disorders in general is a bit of a spectrum of disease. So on one end of the disease, you have something called monoclonal gammopathy of uncertain significance. This is known as MGUS. And what this is we found a small abnormal population of plasma cells. We can sometimes detect this from a blood sample, but many times requires a bone marrow biopsy to confirm that this is a small population. They're abnormal, they're clonal, but by definition, they're not causing any problems. People are not having any symptoms, not having any organ dysfunction, any kidney involvement, or anything like that. So that's MGUS on kind of one end of the spectrum. Typically, people have less, even if they have more than 2 to 3% of the normal plasma cells in the marrow, they have less than 10%. On the far other side of the spectrum is full-blown multiple myeloma, where people often have more than 60% of the cells in the bone marrow are plasma cells, or this population of plasma cells are causing problems, essentially. And then in between that, those are kind of the two ends of the spectrum. In between that is smoldering myeloma, and that's kind of that in between where people have, more plasma cells or a higher level of the immunoglobulin protein, the monoclonal protein in the blood, than what we would consider to meet criteria for MGUS, but not so much as to call this full-blown multiple myeloma. And it represents a little bit of kind of a tricky place. MGUS is something that can often be monitored. There's a low risk of progression to multiple myeloma, often on the order of about 1% per year, and so it can often be monitored. Smoldering myeloma we know has a higher risk of progression to multiple myeloma. That being said, we still don't know the best way to approach this or the best way to treat this. So far, there hasn't been really any data that shows that there's a survival benefit to treating this early. And so the standard of care right now is to kind of understand where you may fall on that spectrum as far as what the risk may be of progression to full-blown myeloma that requires treatment, but essentially just to monitor the disease and often monitor it pretty closely. But this is an area of very active research, certainly is what we should do with smoldering myeloma.
Are there lifestyle changes that you can make at that point to sort of try and make sure it doesn't advance in any way?
So the short answer is overall probably not all that much. Certainly some of the risk factors for development of myeloma and perhaps progression from MGUS or smoldering myeloma to full-blown myeloma include things like occupational exposures to chemicals, benzenes, pesticides. Male gender, for example, is an increased risk of myeloma. There's some data that shows that there's an association between obesity and multiple myeloma or progression from MGUS or smoldering myeloma into multiple myeloma. The association seems to be there. It seems to be kind of a modest association, but appears to be real. There has not yet been a lot of data to show that losing weight or medications to kind of help combat obesity have noticeably decreased the risk or the rates of progression to myeloma, but that's also an area of active research, and it's certainly a promising one.
Yeah, that is one of the questions, actually. Someone asked if there is any research that new obesity drugs, and I guess specifically the ingredients in them, uh, would cause disease progression or help in any way. Um, so we don't know. Is that kind of where we are with that?
So, to my knowledge, there's no evidence that any of the obesity medications or anything caused or put someone at increased risk of progression to multiple myeloma. If anything, the opposite. We don't know yet. That it's certainly an area of research to see if weight loss, either through traditional diet and exercise or with weight loss medications. I think for example, metformin, which is a diabetes medication. There's research to see if that may decrease the rates of progression. But I don't think there's really much data or any reproducible data that shows an increased risk of progression to myeloma with any of the weight loss drugs. So
What about surgical weight loss that is helped by surgery?
yeah, I I think it's an area of sort of unmet need, unknown certainly. Um,
Hmm.
it's tough in something like MGUS where you have maybe 1% progression to multiple myeloma per year. They're technically difficult studies to do. How many patients who have MGUS and are obese would have to have surgery for you to be able to say, oh, hey, actually, if you have surgery instead of having that rate of progression of 1% per year, if you have bariatric surgery, for example, maybe that reduces the rates of progression to 0.8% or 0.6% or something. So I think it's possible, it's unknown, certainly, but I don't think we have the data right now.
Are you, and I know you don't have these numbers with you either, but maybe you know sort of anecdotally, are we seeing more blood cancers? Is there an increase? Is it holding steady? Is there one type that seems to come up more than others?
Yeah, I think I'm not sure about the overall rates of blood cancers in general. I think certainly, as I mentioned, for myeloma, some of actually many of these blood cancers, the leukemias and the lymphomas, the risk factors can be occupational exposures um, but also other things that we have no control over. It's probably random, UV radiation from being outside throughout our lives and other things that cause small amounts of DNA damage. So I think, in the modern era, we're seeing, and as we learn more and more about some of the things that are risk factors for development of cancers, I think that, and we eliminate those, we see some of those rates come down. Um, yeah.
During your fellowship, I have been told that you were admitted to the Gold Humanism Honor Society. Can you tell us about this and how it actually impacts your patient care?
Yeah, it was a really nice and very humbling sort of honor to be uh, nominated or inducted into this society. It's I think the the vision of I think Dr. Arthur Gold started this really to promote awareness and to really foster and nurture the humanistic side of medicine with compassion, scientific excellence, and humanity. And yeah, I felt really, really honored by that. I think that being said, I think there are a lot of people who I have worked with in the past and continue to work with who would be who are excellent candidates for this too. Um, how does it necessarily impact my day to day clinical care? I don't perhaps not very much, but I do I do very much support the mission of really recognizing and wanting to sort of highlight the importance of fostering compassion and warmth and humanity and all of those sometimes kind of intangible elements of medicine. And so I do definitely support the overall mission of this society.
Yeah, that's beautiful. You see your patient as not just a patient and someone that has something for you to solve. It's the whole person and who they are and what they want
Yeah.
from their life. And
Exactly. I mean,
Yeah.
I kind of, cancer, going through a cancer diagnosis, or even even a non-cancerous blood disorder, but certainly any sort of cancer, diagnosis and treatment is hard enough. Is There's a lot going on and a lot there, and I think, absolutely the very kind of top priority needs to be excellent, cutting edge evidence based medicine, no question. And I think within that, there's I think it's fundamentally important to deliver that excellent medical care in a nice way, in a warm, compassionate way. Um, and so, I try to keep both of those things at the forefront of my mind all the time with every patient.
Yeah. There's a lot of people who are incredibly grateful that the Cancer Center is in our community. How can they continue to support it?
Yeah, it's a good question. I guess, I don't know. The short answer is probably, donate money, and reach out to the philanthropy department if you have the means and can make an impact that way. But um, you know really, other ways, come volunteer or do a fundraising event, um, or anything like that. But probably, actually, I mean, I don't know, more important and more realistic for many people, I think, would probably be, give us feedback. I want to hear it. We're a community, a strong and thriving community oncology program, and a thriving, community hospital. I want to know what we can all be doing better, what's working, what's not working. I think really kind of feedback and an open dialogue is the best way that any kind of healthcare provider or healthcare system can both best serve the community and continue to advance and move forward.
Wonderful. Dr. David Gottlieb, thank you so much for joining us today, and welcome. I'm sure you hit the ground running, but we appreciate you taking the time to answer some questions today on Ask the Oncology Expert. Be well.
Thank you so much. Thanks for having me. I'm happy to be here.